Today's event was inspired by one of our PBHA stakeholders, Linda. She has had multiple lived experiences of trauma and has had difficulty living with her trauma. So she was able to open up to a couple of our PBHA members, and it has led to many conversations and discussions, which led to the culmination of today's event with the help of our partners, Panhandle Area Health Education Center and Amarillo College. Now, trauma comes in many forms and impacts individuals regardless of their socioeconomic status, race, gender, or geography. Unaddressed trauma is long-lasting and affects the individual across their lifetime. So that's the reason why we felt today's event was going to be very timely and informative for our attendees to help improve our capacity to address and provide this trauma-informed care in our region. So our first topic covers trauma-informed care in the justice setting. And for that, we have Rick Smithson and Chelsea Ray presenting this information. Rick's previous work experiences included being a mental health specialist with the juveniles for the Texas Correctional Office for offenders with medical or mental impairments. He's also worked with the regional state therapeutic foster care services, as well as an investigator for the Child Protective Services and the lead counselor for the Juvenile Detention Center. He's also a certified trainer for various curriculums and is currently the YES Waiver Program Manager for Texas Panhandle Centers. He just finished restoring an old cargo van with his youngest daughter, and she will be residing in it when she goes to college next year. Chelsea Ray was a teen mother who completed her bachelor's while working as a pharmacy technician. She is currently working as a social worker at Regents Health Network Outreach Clinic, where she does mental health evaluations, psychosocial assessments, and medical social work. She's currently pursuing a master's in counseling and mental health towards her credential as an LPC or licensed professional counselor. So thank you, Rick and Chelsea, for joining us today, and I will turn it over to you guys to share your screen.
All right, so we're going to talk about trauma-informed care in the justice setting, and we'll have some definitions. We're going to show you a video, and then we'll talk about different ways to assess trauma, and then we'll talk about attitudes of trauma-informed care. That trauma has been around obviously a long time, and the way we look at it though is it's not new, but it's been around, and it's really something that we're looking at in our community now in a different way. I think we're thankful for that, and then we'll have questions and a closing. Dr. Gordon Hodes brought the idea of universal precautions to the trauma field in 2005, and he stated we need to presume that clients we serve have a history of trauma, stress, and therefore we need to exercise universal precautions by creating systems of care that are trauma informed. Based on the underlying thought that 50% of the general population have experienced some form of adverse childhood event. And he went on to say that, we need to treat everyone in this human service system as if they have had a traumatic experience. So if you bear with me now and watch a series of videos here.
My parents don't understand. All the drinking and fighting means I'm scared. I'd like a cuddle, perhaps a bedtime story, but mostly I'd like them to stop shouting at me. And sometimes they hit me. Feeling scared every day and not feeling loved or wanted will change me for the rest of my life. Later, I'll have problems at school, problems with alcohol, and I'll get in trouble with the police. What's happening to me right now means I'm more likely to have serious health problems in middle age and die sooner than I should. Doctors say my life is full of adverse childhood experiences, or ACEs. But in my world, this means I see my dad hitting my mum. Dad's got a drinking problem, and mum's always crying, even with the tablets. I am always being shouted at and hit. After the booze and fags, there's not a lot of money for toys or clothes, or even food. I'm getting used to being scared all the time. Now I'm just angry. The doctors say things are changing inside me. My brain isn't learning how to control my feelings properly. My body can't relax like those kids who don't have ACEs, so my body won't be able to repair itself properly when I get older, making it more likely I'll get cancer or heart disease as an adult. It hurts when my parents hit me, but the real damage is hidden, and that damage will be with me for life.
I drink and smoke. They say I'm out of control, but I'm not. It's just my way of coping with my ACEs. I've been in plenty of fights, but what's wrong with that? Kids' punches don't hurt half as much as when my dad hits me. I beat up a kid last week at school because he looked at me weird. Who cares? I ended up with more time out of school. Learning's not for me anyway, and the teachers don't care any more than my parents. I don't like the way anyone looks at me except my girl. She's 16 and pregnant, just like my mum was with me.
So this is where I've ended up. I've got diabetes and cancer's probably on the way. I know these kill you, but I couldn't do without them. I've never had a proper job and I've spent time inside. I hate my kids. I hate their mum too, until she left, so my kids have grown up with ACEs. And now my daughter had her first kid. She's 16. The course of my life was set in the wrong direction a long time ago. I know where I'm heading, and sadly I know where my kids are heading too. This doesn't have to happen. A little help in childhood makes a big difference to where life takes you. When I was a baby, the nurses noticed that my mum wasn't coping and helped her and explained how important my childhood is to the rest of my life. So, with a bit of help, she coped. The police came round after next door complained about the noise from Mum and Dad fighting. They asked how I was feeling. I told them I was scared all the time. Mum and Dad got help. The shouting got better and the hitting stopped. I even got some bedtime stories. I still had problems at school, but the teacher asked me about what was happening at home. I got help controlling my feelings. It wasn't a lot, but it was enough. I'm now married with 2 children, and I've got a job, most of the time. I haven't repeated the same problems with my kids. We got help when being a parent got too much. Our children are ACE-free, and that means their kids stand a good chance of growing up ACE-free as well. Almost half the people in England and Wales experienced one ACE as a child, and 1 in 10 of us suffered 4 or more ACEs. If we stop ACEs, millions of children would not become smokers or binge drinkers, and levels of violence in adults would be cut in half. Fewer ACEs in childhood also means fewer adults developing diseases like cancer, heart disease, and diabetes in middle age. We all need to be ACE aware. Are you? Doctors, police, nurses, teachers, firefighters, and most importantly, parents. The more you know about ACEs, the more you can help stop children growing up with ACEs in their lives. And for those of you who have already suffered ACEs, the more you know, the more you can help yourself and others who have suffered ACEs cope.
So the Kaiser-Permanente study began in the 1990s by Dr. Vincent Felitti. He's a physician with the Kaiser-Permanente Health Plan, and Dr. Albert Anda, cardiovascular epidemiologist. They were both for the Center of Disease Control, and they began to, they published this article in 1998 after a study that goes back even to the 1980s. The study started with the study of obesity in adults and how at first it was how to help Americans lose weight so they would be healthier. But they tied this study, and the study there's a reference to this study in your reference material, and it's a really good study to read. But they found that it was tied to trauma, and to trauma that goes all the way back to childhood, and it was linked to a lot of things more than just obesity. It was linked to depression, and that people who had been traumatized as a child, it led to depression, heart disease, and drinking, and that's where the ACEs study came about. And then people like Dr. Bavilac, who was head of the Nurturing Parenting, began to study this and develop curriculums, and it's tied to CPS, and there's a lot of things tied into this. And it was picked up by the Surgeon General in California. A lot of research was put in there to California into their doing some public access study and their public policies, and then it was developed by the CDC, World Health Organization. You saw it, Great Britain and Wales had put up public service announcements. In Scotland did a lot of research as of last year, did a lot of research into public policies. And we'll talk about that in a minute. The CDC in their current website talks about adults reporting the highest level of ACEs exposure had increased odds of having chronic health conditions, depression, current smoking, heavy drinking, socioeconomic challenges such as unemployment compared to those reporting no ACEs. Women, American Indians, Alaskan Natives, African American Blacks were more likely to experience 4 or more ACEs. Preventing ACEs could have reduced the number of adults who had heart disease by as much as 13%, up to 1.9 million avoided cases, according to their last research in 2017. Preventing ACEs could have reduced the number of adults who were overweight, obese by as much as 2%, up to 2.5 million avoided cases. And preventing ACEs could have reduced the number of adults who had depression by as much as 44%, to 21 million avoided cases of depression. So I'd like for you to look with me at this, the ACEs, the adverse childhood experiences. So I'll try to give you time to look at the ACEs. It's also, you will have it in your reference material to look at later and to have with you. So we can go through and look. The first one I'll read to you so you can kind of understand how the ACEs instrument can be scored. Number 1, did a parent or adult in the household often swear at you or insult you or put you down or humiliate you or act in a way that made you afraid that you might be physically hurt? So it would be either or, and if you can say yes to either one, then you would mark a 1 in the box. And most of the questions are scored that way. So I give you a chance to read through each one of those, and you can score this for yourself. Of course, you're not going to be sharing that with anyone. And so there are 10 of them. So I'll give you a moment to look through those first 5. We'll move on. ACEs are common. About 61% of adults surveyed across 25 states reported that they had experienced at least one type of ACE, and nearly 1 in 6 reported they had experienced 4 or more types of ACEs.
So when we're looking at trauma, a lot of times it can help to kind of define those things. So trauma from the SAMHSA website can be defined as an event, series of events, or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning, mental, physical, social, emotional, or spiritual well-being. Trauma has no boundaries with regards to age, gender, socioeconomic status, race, ethnicity, or sexual orientation. Trauma is a common experience for adults and children in American communities. It is especially common in the lives of people with mental and substance use disorders. For this reason, the need to address trauma is increasingly seen as an important part of effective behavioral health care and an integrated part of healing and recovery process. The effects of a traumatic event place a heavy burden on individuals, families, and communities. So when we're looking at trauma, it can help to define it. It can also help to figure out how do you approach that, whether you work in a mental health community center, whether you work as a social worker, whether you work in the jail, whether you work as a primary care. A lot of times when we approach it, it's important to have empathy and understanding. Empathetic understanding is defined as the ability to feel with clients as opposed to feeling for the client. It's the ability to understand feelings, thoughts, ideas, and experiences by viewing them from the client's frame or reference. A lot of times, something I've learned over the years as somebody who's worked in mental health is it's important when you're working on trauma to meet people where they're at. You have to be able to empathize with how they view their trauma and how it impacts their functioning. So in looking at those things and how we define it, how do we approach it, I created what we call a trauma screener for the justice system or primary care or mental health for people to screen for those things. So part of the screener, it starts off with, are you experiencing any current trauma, abuse, domestic violence, suicidal, or homicidal? The point of that first one is to ensure safety. A lot of times when we're in the middle of crisis or other various situations. The second one is, have you experienced trauma or abuse in the past? Third one, does this impact your functioning at home, social situations, work, or school? What do you experience? When we have trauma, we can have emotional symptoms, we can have physical symptoms as far as stomach problems, chronic health issues, pain, hypertension, things like that. The other thing that I wanted to, part of the screener was to screen for any substance abuse problems, because a lot of times they go hand in hand with mental health and trauma. Once you have this information and we've hit yes and we've identified those things, it's important to provide appropriate referrals based on needs. And at the end of this presentation and the attachments that you'll be sent, the trauma screener will be sent to you, as well as the list of community resources on where to send people when they experience these things.
So I wanted to talk about this attitude of trauma-informed care with all of us that are represented here. And we probably have law enforcement, we have mental health, we have probation, we have CPS, we probably have foster care. And I'm glad that we're all together to discuss it. You know, I started my career a long time ago. You get to say that when you're as old as me. I started as a youth minister. And I just finished school when I was in Dallas. And I was fortunate enough to work at a really large church. And so I drive from my house past the high school to this church that I worked at. And I noticed when I was passing the high school that across the street from it was an old car wash. And there was a group of young people that would gather there before school. And I don't even know how to describe these young people, but you know, they would be over there and they were hanging out, and they were smoking, what they were smoking, but they were hanging out. And I was thinking, they just looked like they were not fitting in. And I knew they were not probably ever going to walk into the door of the church where I worked. And so I got this great idea. At least I thought it was a great idea when I had it. And so I went and got the church van. I went and bought a box of donuts, and I pulled up to where they were gathering. And I walked up holding my box of donuts. And I remember this kid. I'll never forget this kid. And, a long black coat on, and long blonde hair. He walked right up to me, and he hit the bottom of my box of donuts, and they just scattered everywhere. And he slapped me so hard, harder than I'd ever been slapped before, that I just reeled back. And I remember thinking to myself, this did not work out the way I thought this was going to work out this morning. And he says, get away and don't ever come back. So I just kind of, scampered away, humiliated. But my great idea was not the great idea I thought it was. But I'm still concerned that, that something should be done to help these young people. So the next week, I got my box of donuts, I got my church van, and I drove over, and I got there even earlier. And I went up to this young man, and I said, hey, you seem like you're the one in charge here. I'm going to give you the donuts. You do what you want to with them. And I'm going to park way over here. And I just want to talk. I'm not here to preach to anybody. I just want to talk. Anybody wants to talk, they can come over. We'll talk about anything. And I just sat there. And a young man and a young woman, and I came up shyly, and they said, what can we talk to you about? I said, anything you want to. And they wanted to talk about teen pregnancy. And I was able to guess why that was. And we just talked about, how they felt, some options. And through the weeks and through the months, young people would come up, and they want to make sure I always had the donuts. They would come up, and we'd talk about different topics. It was about, sadness or grades or not going to school or what was going on in their homes. And they wanted to talk about traumatic life events for them. I showed up one day, and nobody was there. And as a kid, I always called him Buttons. He goes, hey, Donut Man. I didn't know I had an official title, but I did. He says, Donut Man. And I says, where's everybody at? And he said, well, they're tearing this thing down. He says, so we can't meet here anymore. He says, we're meeting on the edge of the school, right over there on the corner. I says, okay, well, I'll come over there. So, he says, can I carry the donuts? I said, you bet, buddy, you sure can. So we went over there, and then we did that for a few weeks. And some kid brought me a note. And I looked, and it says, Mr. So-and-so wants to meet with you. I'm like, okay. So after we had our little talk, we were talking about a lot of life issues at that point with various kids. Some would come, some wouldn't. So I went to see Mr. So-and-so, which I found out was the principal. He says, so you're Donut Man. So that apparently is my name, yes. And he said, well, two issues. He said, one is you're not supposed to be bringing food onto the school property. Okay. And he says, but we want to give you a classroom to meet these kids in because they seem to be enjoying your presence. So, well, that's great. But the donuts is a part of the deal. He says, okay, that's fine. I ended up getting to meet with these young people for, it was about a total of 4 years. And another school wanted me to come there. So I met with two schools in the Dallas School District and then two other schools in another school district. Toward the end of that time period, that kid with the long black coat and the long hair, I was in a church where, the pastor preaches and then all the other people on staff have to sit up there. It was a horrid event, but anyway, we did that. And one time I was up there and this deacon came up and he handed me a note, which was, the pastor was not very happy about that. But anyway, he called me down. He says, there's a kid, really scary looking kid in a long coat. He says, I have to get you right now. He says, do you want me to get a policeman? And I said, it'll be fine. It's okay. I'll go down. And so we went out, and the kid had walked up to the church. He needed me right now. His mother had died. And he just wanted to sit on the porch. He didn't want to come in. we want to sit on the porch. We want to talk about death, grieving, what life meant. And yes, I think about those kids a whole lot, even now. I mean, even 30, 35 years later. They taught me a lot. They taught me that everybody has trauma. And given an opportunity, most times they just need to talk about it. I learned a lot from those young people. And it makes me think that, that important work that those doctors did at Kaiser Permanente, what we're doing now with trauma-informed care is important. Because all of my experience since then, I had no training. I had no idea what I was doing. There was no curriculum. But just what we do with people and giving them a chance to talk about, it's not what's wrong with me, but it is what's happened to me that has shaped me. It's extremely important. I'd like to share with you two stories. And before I do that, when hearing these stories, it would be really easy for us to judge. It'd be easier for us to judge the consumer. It'd be easy for us to judge the person who's offering the care. But that's not what these stories are for, because in a different situation, maybe everybody was doing the exact right thing. I truly believe from the bottom of my heart that most people do the right thing, or at least they're trying to do the right thing under all circumstances. So many, many years ago, I got a phone call. It was late at night. And the mother says, my daughter is out of control. Can you come over? I says, okay. She said, I've already called the police. I says, okay. So I get there, and it's one of those houses that, the garage door is open. You can see the into the house, from the door there. And there's the mother who's just exasperated, and there's two police officers. And so, and then the daughter, the teen daughter, is standing in the door, just screaming at the top of her voice because she just is having a difficult time controlling herself. And so, I talked to the mother and the officers, and I, see if she needs to go anywhere, or if she's under arrest, or if she's on a mental health hold, and none of that is going on. But the police officer says to me, she is just acting like a spoiled brat. And then he says to me, she needs a good spanking. I had to process if those two words actually were matched up and going together at that time. And he said, I told the mother that we were willing to pull her out and hold her while she gives her that good spanking. He explains to me how that's within her rights to do that. I said, well, it's okay if I go in and talk to her. And so everybody's okay with that. So I go in and ask the girl what's going on. And she was upset. She'd made some cookies, and then her sister tried to eat them all. And she felt like, that wasn't right. And she got mad, threw everything around and cussed everybody out. And I asked her what had happened. I knew what had happened, I think. That's a few weeks ago. She'd run away from home. Was that right for her to do that? Absolutely not. And while she was gone, she had ended up under the influence of substances. And she told a story about someone giving her something. She didn't know drugs were in it. I don't know if that's true or not. Was it right for her to be under the influence of substances? Absolutely not. But while under those substances, she ended up getting raped. It was one of those, brutal rapes. I mean, all rapes are wrong, of course. But I mean, she was bruised and scratched, and it was horrid. So for someone to have that happen, and without consent, to have someone take something from you like that, I mean, she may never get over that, but it's going to take years. And so we talk about how recent that is for her, and then to have maybe someone take something minor from you without consent can trigger some things, and like cookies, and then we talk about is it right for her to throw things around and cuss her mother out, and she knows it's not. And talk about what she needs to do to feel safe again. You know, can she stay at home to do that? Does she need to go somewhere? Does she need assistance? And she's able to, you know, use her safety plan and calm herself down. And then we talk about what needs to happen with mom, what needs to happen with those police officers, and she's able to work herself into a safe situation again. So let's think about trauma-informed care. It's about people thinking about, you know, what's happened to them, what they need to feel safe. And, you know, that way maybe they don't need to be in a situation that's going to re-traumatize them. So now let's move to a different story. A while back, I was about to leave the office, and mom calls me, says, you know, our child is laying in the middle of the floor. She's had an anxiety attack. She can't get up. She's crying. We don't know what to do. We've already called the police. Can you come over? And I said, certainly. So I drive up, and there's two police cruisers, you know, pulling up right in front of me. So I introduce myself. They walk in. One officer goes to the parents. Another officer goes to the child. I follow behind. And the police officer that is dealing with the child stands back, and he introduces himself. And he says, after, you know, he does all the things that any of us would do to establish safety, you know, the other officers establishing safety with the parent. And, he makes sure that she's safe, home's safe. She doesn't need to go anywhere immediately. He says, is there anyone in your home right now? Your mom, your dad, your mental health guy? Is there anyone I can help you call that you need to talk to that would make you feel better right now? She says, well, I kind of like to talk to my mental health guy. He goes, okay. And she goes, it's okay if I get up and go talk to him on the porch. He says, you haven't given me any reason to make me feel that, you know, you're a danger to yourself or you're a danger to others. He goes, if you want to get up and go talk to him, go talk to him. He says, do you need help getting up? She goes, no, I'm okay. He says, okay. He goes, we're here just to help you make you feel better. She goes, well, can I go talk to him on the porch? She goes, this officer says to her, you can go wherever you want that's okay with your parents. He says, we're not here to arrest you or take you anywhere unless you need us to. You take care of yourself right now, young lady. So she goes, we talk on the porch, we work through her safety plan. She comes to a really great safety plan, by the way. And then she says, I think I should tell those police officers what I'm going to do to be safe through the night. I says, well, you want to. So she calls him over, tells him, you know, what her plan is. And he says, well, I'm very proud of you. That sounds like a great safety plan. He says, do you want us to stay for a while or do you want us to go now? She goes, y'all can leave. Then he does this really awesome thing. He says, may I walk toward you and hand you my card? Because we're going to be cruising around all night. Just if something came up, feel free to call us if you need to talk about anything. Very, very careful about her safety, her feeling empowered. And she says, yes. And he walked, handed her his card and says, I hope you feel better tonight. It was picture perfect trauma-informed care. So why does it matter that we do trauma-informed care? Well, first of all and foremost, it's just the human respect factor. And we don't want to be, you know, in a place, I don't want to be in a place where we ever, you know, that I ever re-traumatize someone. And we want to make sure that we don't do that. And it's mostly just about good communication. I went to a home a while back and the parents and the child, they were just having a really difficult time of resolving a conflict. And it's a typical, you know, for any of us who have teenagers, we've had this type of conversation before. And, you know, it was one of those, you know, blistery, stormy, you know, winter nights. And the child's best friend from another state had been kicked out of his house. And of course, the child is saying, you know, we've got to go pick him up. We've got to get him. We've got to bring him to our house. And the parents were saying a typical parent response, a response I think I would have given is, we can't do that. That's kidnapping. And then we're having those kind of conflicts. And I said, I have an idea. Let's do an exercise that sometimes I do. And I says, put your hand over your head and let's make some comments about that are, when we make comments that are just cognitive, just thoughts, such as, hey, it's a nice warm day out today. It's about 75 degrees. I like it when it's nice and warm. Now, these are going to be emotion. Put your hand over your heart here. And these are going to be emotional statements. I don't like it when it's windy. I just feel irritable when the wind's blowing all the time. These are feeling statements. So we explained the rules. And then we said, now let's go through this conversation again. I'll kind of guide you through that. And so we went through the conversation, such as the young man saying, I worry about my friend. I'm afraid he's going to freeze to death tonight. And I feel like we're not doing anything. You aren't listening to me. And of course, the dad is saying, I'm not going to be getting out on these highways. No, we're not going to do anything. And the young man is saying, I feel like you're heartless and you don't care about my friend and you don't care about what I'm feeling. And so we keep doing this until finally, you know, mom says, I get what we're doing. Son, I'm sorry that you're worried about your friend. What can we do? And not that I would ever expect them to get out on the highway or to ever go and kidnap another person's child. But they started having some communication about, oh, what can we do? Not just an automatic, go to your room, I'm tired of talking about it. So then they start problem solving. The thing I like about this process is when we're doing these heart exercises with his family, I look over at Dad, and Dad's got tears in his eyes. And he says, I just realized I've never really communicated with my son before until tonight. I'm so busy telling him no that I'm never listening to where his heart is. So the purpose of this conversation is to say, sometimes we get so stuck in mind what has to be done, we forget where the heart of our topics are. We talked about the World Health Organization and the CDC that have studied the ACEs. There's some really neat things going on across the country. Scotland has done some really good work about trauma-informed care in law enforcement, in CPS, and this publication is in your reference material. And I want you to, print that off and read the whole thing, unless you're just really interested in that. But they, starting on page 40 on, they've done some things such as jail diversion, decriminalization when possible, youth parliament, family programs, and then some really neat experimental police programs. So if you're interested in that kind of stuff, I suggest you actually look into that document. Chelsea and I talked about when we were doing this is that we really don't want you to think that we expect you to lay down, your main position of being a CPS investigator or a law enforcement officer and take, that hat off and become a social worker or a counselor. That's not who you are. And you don't have time for that. But I think that looking at the ACEs as we did, that maybe there's a way for you to utilize that information in assessing the people you do come in contact with. You know, you don't have time to ask them to fill out that form and then look at the way that they've been traumatized as a child. And we wouldn't expect you to do that. But I do think if you had a field version of that, not for them to fill out at all, but for you to look at and to say, okay, if I've got this and I've got this fresh in my mind, maybe I can assess the persons I come in contact with and make some assumptions. Because if they're acting in a certain way, that tells me that all probability, maybe they're dealing with this. Such as, and so we made you a field version here. That's also in your handout section. Is, you know, if a person I come in contact with is keeping their head down, and they're not making eye contact with me, and they're being very timid, there's a good chance that possibly they were yelled and cussed at or threatened a lot. And so there's some things that I can do. And so the way I adapt is, you know, I kind of keep a little bit more distance with those people. I keep my eyes down. I don't make a lot of direct eye-to-eye contact with those people. And I do what I can do to give them some comfort level until they can get used to their comfort with me. And that's a way I can be a little trauma informed with those people. So if that makes sense, then I hope that this piece is helpful to you.
A lot of times when working at trauma, I always think it's important to reinforce the amount of resiliency it takes to get up every day and do those things, and to keep the faith up and keep strong and get out of bed, and the amount of strength it takes to get treatment or get help. A lot of times it can also help to know where community resources are at, when and where, how to do that. Also, how to avoid secondary trauma to yourself as a practitioner or burnout in a lot of ways. And the last thing I think that's really important is how to check your own biases. This is something I've learned a lot over the last few years and working in mental health, is how does my point of view or things that I've been through impact how I'm seeing somebody else in their trauma. A lot of times when we're trying to work on those things, or whether we're in CPS or we're in the police or we're probation or we're mental health or we're a social worker, we have to meet people where they're at and what they're willing to work on. So all in all, when you're trying to be more trauma informed, I think it's important to screen for those things, but also check where you are and how you can improve those things. So I think we're going to start the Q&A now, which I'm trying to remember how to do that. Sorry, everybody. You want to go to stop share?
Sure.
Okay. Q&A. Emma Crane, what impact does ACEs have on sentencing guidelines for youth? You want to take that one?
Sure.
A lot of ACEs anymore.
Yeah, I think I'm the only program I know that uses ACEs. So, okay, so is this how we answer?
I think you're supposed to hit the button.
Right here?
I think. Don't quote me on that. It's Zoom.
Oh.
Or you just answer it live now. So what impact does ACEs have on our sentencings for our youth currently?
Okay.
Yeah, you gotta answer it live.
Live?
So right now.
By speaking?
Yes.
Oh. Okay. Okay, so what impact does ACEs have on sentencing guidelines of youth?
Mhm.
You know, I don't know that either one of our local probation departments, Potter County or Randall County, actually utilizes the ACEs. I utilize ACEs in my program, but I don't know that it's ever been used in a adjudication process. But I do think that you know, both of our local juvenile programs look at, you know, the background of a young person and what their mental health situation is. I think that is a consideration.
Okay, so next one, do social workers and school systems use ACEs? Not that you're aware of currently?
Not that I'm aware of.
Okay. Let's see here. Desiree says she misses you.
I miss her too. Well, I certainly miss you.
Does anybody have any questions on how they can implement trauma-informed care? Oh, here's one that just came in. It says, is there any reason we only ask about the abuse to moms/stepmoms? I've worked with a number of families where the male or parent caregiver is being attacked by a female partner on a regular basis. I assume you're, Chad, you're talking about the ACEs?
Chad, that's a very good question. I wondered about that too. I'm wondering if it's just because of the time frame in which the ACEs was manufactured.
That was done in the 90s, wasn't it?
Mhm.
Yeah, it was done in the 90s. Oh, no, that came through. It says, would it be appropriate or okay to print out the ACEs questionnaire and give it to kiddos to fill out during an assessment?
Yes, definitely. It's a made to be reproduced.
I also, even working with adults,
Mhm.
will utilize the ACEs to ask and screen for those things.
Yes, Kelly, it is made to be reproduced.
And also in the attachments that you guys will get at the end of it, you'll get the trauma screener, you'll get the ACEs. We created a list of community resources and also an LGBTQIA resource list as well.
Yes.
Says, and to do it in a way where parents can't see.
Yes, I think that's okay.
Says, any tip on how to use ACEs or the ACEs questionnaire with students or in working with clients? I find sometimes that just sitting with them and filling it out with them can help a lot, either by you filling it out yourself. I tend to work mostly with adults, so it's kind of a little different,
Oh, yeah.
but you work with kids.
Yeah.
Mhm.
You know, I want to add to that. Can I add to it?
You just say it out loud.
Oh, okay.
Yeah.
Okay. Maria, I will tell you my experience is that you may end up making a CPS report though.
Okay, Terry Campbell says, do you think we will see ACEs information later in college education in psych or social sciences?
Possibly.
Any other questions at this time about the ACEs or trauma screener or how that can be better done or? Somebody asked you, have you seen it used successfully in a school setting?
I don't know anyone who's using it, no.
Is there a magic number where if a kiddo answers 1 to so many questions, CPS has to be notified case by case? I think it depends on that level of safety in the current moment, doesn't it?
Right.
Yeah. As far as that, I would say no. I think it just depends on your safety environment, what the current environment is, because that can also refer to the past. A lot of times, as if that has ever happened, the kid may be in a current situation where they're safe and they no longer need that referral to CPS. Richard Stump, we have a group of juvenile supervision officers here. They're wondering if you could speak about kids with past trauma and consequences. Okay. You want to answer that?
Yeah, I think that many of the kids who are acting out, that trauma is a big part of that.
I think there's something to be said too, is are we looking at the negative behavior or are we actually looking at where it's coming from? A lot of times that's a secondary thing of something else that's going on. And if we can meet somebody where it's coming from and work on those things, then I think you'll have a better outcome with it.
You might look at that paperwork from Scotland. It really does address that.
And that's the public health one.
Yes.
Attached in the PowerPoint, which those will be available as well.